And I am happy, though, to be here in Greenville. What a great place to live, especially after living in Atlanta for about 20 years. We're going to move on to a little lighter topic, and we'll talk about eye tumors. It's hard to condense a topic this big and down into 25 minutes, so I try to reduce it down as much as I can. I have no financial disclosures. I've got a lot of slides, so I'm going to try to move as fast as I can and see if I can get done in now 24 minutes. I'm going to talk briefly about a couple lesions that masquerade as tumors, and then the four main choroidal lesions that I'm going to talk about. If you have them on your differential, you'll probably get or if you know the difference between the four, you can make the diagnosis at least 90–95% of the time. That would be circumscribed choroidal hemangioma, choroidal nevus, melanoma, and metastatic tumors. Choroidals, as you know, are accumulation of fluid, a serum or blood in the potential suprachoroidal space between the sclera and the choroid. These, when you see these, they look a lot like tumors. They're common after, in cases of hypotony. I think the glaucoma doctors probably see these after tube shunts or over-filtering surgeries. Trauma, Valsalva maneuver, posterior scleritis. They can also be spontaneous. This was a patient of a choroidal that I took silicone oil out. The patient wanted to be under general anesthesia. I left the room before they extubated her, and she obviously valsalved. And on post-op day 1, I saw this large lesion in the eye, and I know I didn't see a melanoma at the end of the case, but you can see this large dome-shaped lesion. This was her ultrasound on the left the day after the surgery, and I knew right away what it was and just monitored her for a while, and you can see this after a few weeks, this lesion is resolving spontaneously. This was a patient that was sent in. I think I was at Emory when I saw this patient, sent in for a tumor after cataract surgery. I did an angiogram just to kind of show what these choroidals will look like. I knew exactly what it was when I saw the patient, but you can see how the lesion stays dark on the angiogram there on the right side of the photos, showing that this does not have a blood supply. There's no hyperfluorescence of the lesion. Serous choroidals may cause mild discomfort. Hemorrhagic choroidals are often painful. They're often mobile on ultrasound. As you can see on that ultrasound that I have, a little video going there, you can kind of see it jiggle with the saccadic eye movements during the ultrasound. So these lesions don't show spontaneous vascular pulsations, and they get smaller with time. Peripheral exudative hemorrhagic choroidal retinopathy, affectionately known as Pecker. This was another lesion that is frequently referred in for melanoma. It's a degenerative process of the peripheral retina. There's subretinal, sub-RP hemorrhages and exudative masses that can mimic melanoma. It's common in elderly Caucasian females. Approximately 30% of these are bilateral, and most of them stabilize or regress without treatment. This one is obviously exaggerated because it also involves the posterior pole. Here's another patient. These patients are often asymptomatic. They're seen on routine exam, and these peripheral lesions are noted. This patient was sent in for possible bleeding melanoma. The lesions are most commonly in the inferior temporal quadrants, and there's usually chronic changes noted in the peripheral retina of these patients, usually in both eyes. I always look very carefully at the other eye, because it really does clinch the diagnosis when you see bilateral lesions. If you just follow these over time, you can see now the blood is oxidized and starting to resolve on its own, and usually they require no treatment. It's amazing how they're asymptomatic almost always. On ultrasound, you'll see a dome-shaped, often multilobular lesion, but the internal reflectivity has variable qualities. It could be high, medium, or low. And there's this thing called clot retraction cleft. It's something I kind of learned recently, where you can see the choroid almost pulling away from the sclera there, and I've got an arrow that points to it. Melanoma, it's almost exactly the opposite. The melanomas tend to invade or into the sclera, and so you see more of scleral excavation in melanoma. This is another patient that was referred in for possible melanoma. And I have to say, these Optos images make everything look like melanoma. And I'll show you later some more pictures. But you know, when I looked at this, I thought, this looks kind of like a peripheral PED, looked kind of translucent. And I told my technician, I said, this is probably a PED. We did the ultrasound. And you can tell that's baseline internal reflectivity. There's a little bit of exudative fluid, followed it, and they resolved spontaneously. So here's the 4 most common choroidal lesions that you need to be aware of, and if you can name them, then you probably can diagnose every one of these. And you can see on the left, number 1, that's a circumscribed choroidal hemangioma. Number 2, choroidal nevus. Number 3, classic melanoma. Number 4, metastatic tumor. So we're going to talk a little bit about each one of these. I'm going to start with this case presentation. This is a 73-year-old male that I saw a few months ago, referred for this lesion adjacent to the optic nerve, was not noted on the exam last year. Patient's asymptomatic in 2020. If you look at that color photograph, now this is a TopCon photo, so you don't see it that well. This is what you see when you look in. These things are sometimes often difficult to visualize, especially with a 90 diopter lens, because the light's so bright, it just washes it out. They're best seen, I think, wide viewing. But I did an angiogram, and you can see this thing's hyperfluorescing. Went ahead and did OCT. You can see the lesions definitely in the choroid. You can see some subretinal fluid. And so is this a small melanoma that we need to irradiate or enucleate? Of course not. This is a choroidal hemangioma. So circumscribed choroidal hemangiomas are benign dome-shaped reddish tumors, usually in the posterior pole, and they blend in with the surrounding choroid. They're usually diagnosed between the 2nd and 4th decade of life. They have sporadic occurrence. Usually they're asymptomatic. Subretinal fluid from the tumor can cause vision loss. I throw this montage of choroidal hemangiomas up here just to show you. Every one of those photos has a hemangioma in there, but none of them really jump out. Some of them do more than others, but again, I want to emphasize how these lesions just blend in. They have this reddish appearance. And now here is the photo. I wanted to compare the Optos photo. The pictures on the left, top one's a TopCon, bottom one's an Optos, both taken on the same day. But when you use that red and green laser light to make the photo, it gives them a pigmented look. And so these are frequently sent in for melanoma. Whereas the true, if you actually just look at them yourself, you can tell this thing is not a pigmented lesion. Fundus autofluorescence shows there is some lipofuscin. That's the hyperautofluorescence you see at the edge. OCT shows some subretinal fluid. And on B-scan, you could see a dome-shaped lesion. B-scan's the real clincher, though. Choroidal hemangiomas have high internal reflectivity. On diagnostic A-scan, you can see where that arrow is pointing. Your first spike is the retina spike, and as the sound waves pass through the tumor, the spikes stay very high, so you have high internal reflectivity. And even though these are vascular lesions, you do not see pulsations like you will in melanoma. Management, most of these are just managed conservatively with observation. Even when they have a macula on a ski slope, they're almost asymptomatic. They probably have a hyperopic shift in that eye. For the tumors that do exude, PDT works great. It's hard to get it covered. The insurances don't like to cover it. But anybody in the tumor world knows that that's the mainstay of treatment for these leaking hemangiomas. This bottom photos was a hemangioma that was sent in when I was at Emory for a possible tumor, and we did PDT the lesion, and it totally collapsed. So the clinical pearl for hemangiomas is that these are reddish lesions that blend into the surrounding fundus. They're often difficult to visualize. They're best seen on wide field viewing with a binocular indirect ophthalmoscope. They're usually located posteriorly. OCT is helpful, but ultrasound is the diagnostic test. We're going to move on to choroidal nevi. You see these? I see them all day long. We split all of our new patients up between the 10 of us in our group, but I get all the pigmented lesions. So all my new patients are nevi or masses. They're present in a high percentage of the Caucasian population. They're probably present in about half of my patients. They're not present at birth, but they develop or become pigmented in the first couple decades of life. Choroidal nevi are flat or slightly raised. They're usually less than 2 millimeters thick. They can be amelanotic. They can have a halo. Drusen over a nevus is common. That's usually a sign of chronicity. The same with the RPE changes that you see. Orange pigment is less common, but can be there. And if you see blood there, it's probably a benign lesion because they're more commonly associated with choroidal neovascular membranes are. It's rare to see small melanomas bleed. Management for a nevus is photo document and document their elevation. Posterior lesions, I like to do OCT through them. With OCT, you're measuring in microns. With ultrasound, you're measuring in millimeters or tenth of millimeters, and these things don't even hardly show up on an ultrasound. I would say the majority of my referrals of nevi are sent in because they're atypical appearing. I don't know what there are, I guess some typical ones, I guess the last picture I showed you, but these are all choroidal nevi. They're sent in because they have indistinct borders, or because they have funny color, or they have a large size, or they're near the nerve. And I agree, you know, I think they all need to be evaluated, but I go through the same scenario every time I see these. It's like, okay, what are the risk factors, and we'll go over all that. Management of nevi, so a non-suspicious nevus, fundus photographs, and observe yearly. Suspicious nevi, that is something, a nevus that has 2 or more high-risk features, should be monitored more frequently, about every 6 months. We're going to move on to ocular melanoma. This is the big differential we don't want to miss. Uveal melanoma are derived from neurocrest melanocytes in the uveal tract. 90%, 95% of the melanomas occur in the posterior uveal tract, 5% in the iris. It is the most common primary intraocular malignancy in adults. It accounts for 5 to 10% of all melanoma. Obviously, the other 95% of melanoma occur on the skin. Incidence of 6 to 8 cases per million. Median age is around 60 years old. It's rare in non-white races. I've seen it in every race. Maybe not Asian, but I think I've treated every other race with melanoma. No known association with sunlight or environmental exposures. These tumors are deadly when they metastasize. They most often metastasize via the bloodstream to the liver. And most patients have no known family history, although I have treated father and daughter once or twice in my career. The clinical diagnosis of melanoma is made with greater than 95% accuracy just based on examination alone. And you guys know all these risk factors. The features that you look for are thickness, fluid, symptoms, orange pigment. Is it at the margin of the disc, and is there ultrasound hollowness? The other 2 features are atrophy, a halo of atrophy or drusen. All these clinical features are where the Shields coined their mnemonic, you know, to find small ocular melanoma, using helpful hints daily. That'll help you remember what clinical features to look for. Ultrasound is the key diagnostic test. It gives you information about shape, the acoustic hollowness, and vascularity. Angiography, again, it will tell you if there's vascularity. High-risk features that we just talked about. Thickness greater than 2 millimeters, fluid, symptoms, orange pigment, is at the margin of the disc, and is it hollow on ultrasound? So again, when somebody is sent in with a pigmented lesion, I go through this checklist. I don't care what it looks like. I go through this checklist, and do they have these features? Sometimes you see them and you know, wow, this is just a nevus. Sometimes you see them and like, wow, this is definitely a melanoma. And then other times, like, I'm not sure, let's watch it, it's suspicious. Low risk features are the halo of atrophy and drusen. The photos there, you can see the top one is a small melanoma. Look at all the orange pigment. It's in the fovea. This patient's symptomatic. And then the bottom photo is a typical choroidal nevus with drusen. Ultrasound is the most important ancillary study. Diagnostic A scan, like I said, shows low to medium internal reflectivity. B scan will give you information regarding relative size and shape configuration. It also gives you information regarding vascularity within the tumor, which is the hallmark of melanoma. Ultrasound features of these choroidal lesions, we talk about high, medium, and low. The one thing I remember from residency first year was high, hemangioma high, met medium, and melanoma is low, medium to low. So it's kind of how you can remember. You can see the 3 ultrasounds there. The top one shows what a high internal reflectivity would look like versus medium in the bottom one. That first spike after the vitreous cavity is the retina spike. As the sound waves pass through the tumor, Hemangioma, the A scan stays high. Mets, usually the A scan will drop down, and melanoma will drop lower. You can also see the choroidal spike at the back, the scleral spike, and so really you can get an idea of the thickness of the tumor by measuring the distance between that retina spike and the scleral spike. So you can see that bottom one was a pretty thick melanoma, that ultrasound. The features of the configuration of melanomas, most commonly these are dome-shaped tumors like you see on the right with an exudative detachment. The photo on the left is a collar button configuration, which is pathognomonic for melanoma. That's where the tumor is broken through the Bruch's membrane, frequently accompanied with vitreous hemorrhage. Ultrasound can also tell you if this tumor is growing out the back of the eye. This was a small melanoma, and you can see my arrow pointing to that lucency behind the sclera there, where this tumor had started to exit through one of the emissary canals, the posterior ciliary artery canal. This is a great example of vascularity on an ultrasound. You can see it looks like a beehive inside that tumor, and that's the blood flow within the tumor. So I put this up here because it's such a great example, I think, of vascularity. So does melanoma arise from a pre-existing nevus, or does it arise de novo? And I think it's either. And this is a good example of one. I actually followed this patient from 2014 to 2019. The last time I saw the patient in 19 is that photo on the left, and then the patient disappeared. And this was a chronic appearing lesion. Look at all the RPE changes, the subretinal fibrosis over the dome of this tumor. And after following it for 5 years, I'm thinking this is never going to change. And this has now become my poster child for monitoring these things forever. The patient was sent back in 23, so last summer, for a retinal detachment. Turned out this is a vitreous hemorrhage. But I have those arrows pointing at the same bifurcation of the blood vessel, and you can see new growth underneath that white arrow there. And that black arrow points to a small little collar button that's present in 2023 that was not present in 2019. So after all those years, this thing declared itself and started growing. This was a patient that I also saw last summer, sent in for a small melanoma. This lesion is only 1.2 millimeters thick, and it's next to the nerve. There's orange pigment. The patient had symptoms, so I had every high-risk feature except size or thickness. And the referring ophthalmologist, Savannah, I contacted him and said, do you have any previous photos of this? Because I agree, this is a small melanoma. And sure enough, the ophthalmologist who found this was doing OCTs of the optic nerve for a glaucoma evaluation. In August of 22, I have those arrows pointing at the same bifurcation. August of 22, maybe there's a little bit of a shadow at the tip of my arrow there. And 6 months later, you're starting to see something else. And then another 7 months later, and you see that this thing has evolved in just a matter of really about a year, a little over a year. So management of uveal melanoma is radiation, brachytherapy, proton beam irradiation. Every now and then, maybe half a dozen times a year, I have to nucleate a tumor or nucleate an eye for a melanoma. And there are rare cases where we just observe them. Patients are late 90s, or probably wouldn't survive a surgery, or they're not good surgical candidates, so we just watch them. But that's rare. Brachytherapy is the most common method. There are different isotopes we use. That's a picture of a radioactive plaque. These plaques now, compared to the COMS plaques, are so much nicer. They're very thin. Each little slot will house a radioactive seed. Local tumor control rates are greater than 90%. However, dose-dependent radiation complications will affect vision in half the patients. Of course, depends on how close the tumor is to the optic nerve or the macula. These patients are taken to the operating room. This is an intraoperative photo. Any muscle that's in the way is disinserted. Transillumination is performed. You can see the tumor shadow right there on the sclera. Take a marking pen, mark the edges of the tumor, place the plaque right over it, and secure it to the globe. This is placing the plaque on. This was a tumor that was in the ciliary body, so you can see the notch in the plaque for the cornea. The plaque is placed. Ultrasound is performed. You can see the radioactive plaque behind the tumor in that photo on the right. Make sure that the tumor is covered 360 degrees. The conjunctiva is closed, and the patient's sent home for 4 to 7 days, depending on your OR schedule. They just dose the radioactive plaque differently if they're there for 7 days versus 4 days. They do get the same dose of radiation to the apex of the tumor. And then I follow these patients forever. I've never told a patient they don't need to come back to me anymore. And it's really not just to make sure we have local tumor control, but it's more for the metastatic surveillance. This was a pre-op planning on the left. Some of these tumors have very thin edges that you don't see on ultrasound. But I tell you what, that ruler on the Optos has made this a pretty easy way to measure these tumors now. And it's very accurate too. And so that's a pre-treatment, and then a couple years later you can see there's still a shadow of the tumor, but you can tell it's nicely regressed there. Again, this was a patient I saw, a young female, last summer with a 9.5 millimeter tumor. Could have easily been enucleated. I told her we can try a plaque. You can see how much this has regressed in just 7 months. The tumor on the ultrasound on the left was her pre-treatment ultrasound, and the tumor on the right was when I saw her last February. Enucleation for uveal melanoma, patients with very large tumors, too large to plaque. Patients with severe secondary glaucoma, they sometimes present with pressures of 60, all the exudation and crowding, everything pushed forward. You can't really treat their glaucoma very well. Tumors that invade the optic nerve, or tumors that have failed radiation treatment. This was a patient. That first one was a 38-year-old pregnant female that underwent enucleation after she gave birth. This was a patient I saw here a couple years ago with a pressure of 50, and you could see a diffuse melanoma involving his iris, his ciliary body, and the choroid. Underwent primary enucleation as well. I'm going to talk last about metastatic tumors. I'm going to start with another case presentation of a 71-year-old that was referred from the VA. I think this was last year. For a possible hemangioma or amelanotic melanoma, the patient was complaining of blurred vision for the past 2 months. The lesion was not noted on a fundus exam 6 months earlier. I had notes from the VA. The patient's an everyday smoker for 50 years, and his vision improves to 20/30 with a pinhole. And the VA had a refraction on there that showed that with a hyperopic shift, he could see clearly again. So here was his clinical examination. There were a lot of things that don't go along with hemangioma, and a lot of things that made me suspicious of something else, his smoking history. But he's got an amelanotic tumor in the macula. You can see the ultrasound on the top right and the OCT on the bottom right. He's got a hyperopic shift due to that lesion growing under his fovea. Took a long time for me to explain to him that I was more concerned about his life than his vision. He couldn't get over the fact that he couldn't see very well, and that I wasn't that concerned about it. I sent him for a CT scan, and he had a mass in his lung consistent with primary lung cancer, and referred to oncology for bronchoscopy, and PET scan showed he had widespread metastasis. Metastatic tumors are the most common form of intraocular malignancy, not primary, but most common form of intraocular malignancy. They are spread to the eye via the bloodstream. 90% of them occur in the posterior choroid, and less than 10% are in the iris or ciliary body. Metastasis to the retina, optic disc, and vitreous are uncommon. This was a patient that I saw a few years ago with metastatic renal cell, presented with a hyphema. Once the blood cleared, you could see this amelanotic lesion in the anterior chamber. Most common uveal metastases originate from the breast in women, and they originate from the lung in men. 25% of the patients with metastasis have no known history of cancer. And when you're suspicious, I usually order a CT, chest, abdomen, pelvis. Usually you can find an answer. Sometimes you can't, and those are the ones that end up going to biopsy. Even if when there's no detectable lesion anywhere else, then we have to go to the eye. Metastatic tumors are amelanotic. They're usually in the posterior pole. They can be multifocal and bilateral, and then you can get exudative retinal detachments. We talked a little bit about ultrasound. They're dome-shaped or plateau-shaped with medium internal reflectivity. And treatment for these lesions is external beam. These lesions respond very well to external beam radiation. They're referred to medical oncology for treatment of their systemic disease. And rarely we'll just observe them if they're not threatening the vision. And only rarely have I ever had to do brachytherapy for one of these tumors. Okay, I think I'm 27 seconds over time. I have 4 minutes left.
I have a question. So, you know, looking at everything you talked about this morning, I think it bodes to people need to put on headsets and look with indirects. A lot of people are just doing 90s and they're missing, or they're using an Optos, which only goes out 120 degrees, to your point. So I just think we need to be aware of that and don't get sloppy, put your headset on.
Couldn't agree more. I really don't like Optos photos, but sometimes, you know, they do give you that nice overall picture, but the colors are so bad on them. You know, like I said, everything looks so different with a red-green laser light versus a white light. So I still try to get, you know, the Topcon photos. Optos are great for measuring and for localizing and things like that, but it does not replace looking yourself. And especially those hemangiomas, you know, they're sent in for melanoma, and if you look at them, you can clearly see this is a reddish lesion. So I agree.
What is the cure rate for ocular melanoma? Meaning no metastasis, you treated it in the eye, patient is cured for the rest of their life.
That's a good question, and I don't think anybody ever really knows the answer, because I don't think you can ever declare yourself cured. You know, I talked to Mike Humanek. He's a medical oncologist in Spartanburg, and he's actually using the ChemTrack there. He got it. I mean, you don't have to go to MUSC. You don't have to go to Emory to get this treatment now. And he had a patient. He texted me the other day. He goes, I just had a patient walk in, had a nucleation at Wake Forest in 2004 with widespread metastatic melanoma 20 years later. I think my longest follow-up or recurrence I've seen is, I know I've seen 9 years a couple times. You know, the patient, the tumor's controlled, the tumor's dead, and 9 years later they develop a lesion in their liver. So, you know, there's no consensus. And I did a thing at the Academy with Evan Gregutis, you know, the pro-con, and the pro-con was talking about screening. And so I was pro-screening, he was con-screening. And my argument, you know, I sent out a survey monkey to all the ocular oncologists that I knew, 50 of them at least in the country. Do you screen? Almost everybody does. How often do you screen? There was no consensus. How many years do you screen? There was no consensus. Some people 5 years, 10 years, some people 15, some people for life. What do you do to screen? Do you do CT scan, liver function testing, you know, the COMP study, they did LFTs and chest x-ray, PET scan, CT, MRI. There was no consensus on anything on how to screen, how often to screen. So your cure rate, I think if you look at overall, about half of the tumors will metastasize. And we're better now at identifying which ones with genetic testing, but even with genetic testing, it's not 100%. You know, I've seen class 1 tumors metastasize, and I've seen patients still alive 10 years later with a class 2 tumor. You know, and those patients have a 76% chance of metastasis in 5 years. So I think that, and I tell the patients, I go, you know, we probably should keep screening you, because this can show up 20 years later. And, you know, I'm sure it bums them out, too, to think that they're, unlike a lot of cancers, you know, it's like 5 years, you're cancer-free, you're probably cured. I just don't think that's that case for melanoma.
What do you do for screening?
I alternate CT and ultrasound.
Repeat the question.
And if
The question was, what do you do for screening?
liver ultrasound, and if they opt for a biopsy, and they have a high-risk tumor, I'll biopsy them. I talk to them every time. I could talk you into a biopsy, and I could talk you out of a biopsy, so I try to be as objective as I can when it comes to biopsy. throw it out there because they'll get on Facebook and say he didn't say anything to me about biopsy. So if a patient has a tumor biopsy and they come back with a high-risk tumor, then they get screened every 3 times a year, so maybe every 4 months. I might even refer them to a medical oncologist and let them do the screening, because those guys do a lot of PET scans. They believe in PET scans. I don't know if it's a lot more sensitive than CT or MRI. Sometimes it's hard to get MRI scan. I think MRI is the most sensitive, but insurances don't like to pay for it. You know, it's not in their normal protocol for screening. So it's usually pretty easy to get CT scans. Of course, they get a dose of radiation with that every time too. COM study used liver ultrasound. So as long as you're screening, I think you're going to pick them up. But some of them might pick them up a little. You know, these tumors have to be at least 2 millimeters in size before they're diagnosed with an image, with an MRI. And by that time, there's probably 1 billion cells, you know, to make it that big. And so, you know, but usually by the time you do see something, it's probably widespread, or they have miliary disease that doesn't even show up on a scan. Okay, thank you.